We're going to start the session today with Katie Whittle, our Head of Programmes at the Innovation Agency. She'll be talking to us about an overview of the work that we do here at the Academic Health Science Network. Then we'll move on to Emma Rickards. Emma is a respiratory nurse consultant at Knowsley Community Respiratory Service. Emma's going to talk to us about the virtual ward model and a care bundles overview as well. Then we're going to talk with Dr. Benita Kane, Respiratory Lead for Health Innovation Manchester, who's got a very interesting title to her presentation, so 50 Shades of Grey, Standardising the Response to the NACAP Audit. And then we'll move on to Samantha Pillsworth, a Consultant Respiratory Physiotherapist for Knowsley Community Respiratory Service. Samantha's going to talk to us about how the early bird catches the worm, the positive impacts of respiratory rehab. And then we're going to talk to Tom Myers, who's an analyst from Unity Insights. We're going to talk about the national and local improvement for the bundles work that's been happening and celebrating the success of that work as well. And then we'll take some time towards the end of our session today just to wrap up and talk about service sustainability, and then hopefully take some questions as we go through. But we have got a little bit of time at the end of the agenda to go through any further questions. So can't wait to get started. What I'll do is, as our speakers are talking, if we need to, I'll give a little bit of a prompt on times. And then if you'd like to raise any questions in the chat, then please do. So Katie, I'll hand over to you. Thank you.
Thanks, Verity. Can everybody see my screen?
Yep.
Okay, so I can't. That's interesting. Let me just try that again. Okay, so my name's Katie Whittle. I'm Head of Programmes for Patient Safety here at the Innovation Agency, and I'm just going to give you a bit of an overview to who we are and the work that we do, and the National Patient Safety Programmes which we're commissioned to deliver. So I'll just pop onto that next slide. Okay, so we are the Innovation Agency. We're one of 15 academic health science networks, and we are real catalysts for innovation, helping people facilitate change across the whole health and social care economy, improving health and driving down costs and stimulating economic growth. That's what we as Allied Healthcare Science Network have been commissioned to do by NHS England. We are in a really privileged position that we connect regional networks for both from the NHS and academic organisations, local authorities, SMEs and third sector businesses, really to respond to the diverse needs of our patients and our population through partnership and collaborative working. So it's a real privilege that we can bring so many people together to meet those needs, but also to bring about new adoption of new concepts into the health and social care service also. So we are a collaboration. There are 15 of us, and we were set up by NHS England in 2013, re-licensed in 2018 to operate as the key innovation arm of the NHS. We are just going through recommission at the moment, and hopefully we'll have the outcome of that within the next few weeks. And we're hoping for a 5-year extension on the work that we're doing there. So you can see here there are 15 of us, and we are one of 4 in the north, and we collaborate really, really closely to make sure that we are standardising the work that we do across England. So the NHS Healthcare Science Networks commission host the patient safety collaboratives, and we play an essential role in identifying the spread of safer initiatives within the NHS and industry, ensuring these are shared and implemented throughout the system. And we're funded through the nationally coordinated through it's NHS England and Improvement. Now, it was NHSI, but now they've formed together with regional patient safety collaboratives, which are organised and delivered locally. So we have national programmes of work, and we standardise the way in which we're approaching that, and then we can determine how we're going to deliver that locally and across our North West Coast footprint. And we play an increased role in supporting the ICSs as they are developing now to deliver their obligations related to patient safety. So we know that our structures are forming. They're still in their infancy at the moment, but we have appointed medical directors and nursing chief of finance as well. So we can see those structures forming. This will be a little bit of a transition year, but we are really well placed within the system to help support the delivery of their national programmes and priorities as well. And we make sure that we align them. So what does our patch look like? Well, we cover South Cumbria, Lancashire, Merseyside and Cheshire. We've got a population of 4.4 million, we've got 13 acute trusts. We've got just shy of 2,000 care homes, have about 600 GP practices. So it's a really, really large area that we cover. It's a really diverse population where we've got urban, rural, city environments. We have really high levels of deprivation as well. So we have a huge focus on our health inequalities. And I think you'll hear from Anita later about how we're doing that in the North West Coast and aligning our work with the core 20+5 work also. So the team within the Innovation Agency, we have the Patient Safety and Care Improvement team, and that is us. And we host the Patient Safety Collaborative as well. We have a PPI team, so we always make sure that we listen to the voices of those accessing, utilising and delivering our systems, our work and our programmes. Systems partnership team, so this team really at the moment are really embedding us in the ICS and understanding who our real key stakeholders are within the footprint so that we can work and align our work properly. Coaching Academy, where we support QI initiatives and human factors and any coaching that's available as well. And then we have our digital enterprise and growth and communications team to support the work that we're doing. Really diverse backgrounds. We have clinicians, journalists, people with a research background, those experiencing commissioning, mental health, learning disability. So we've got a real diverse our staff got a real diverse background and bring a wealth of expertise and knowledge to the work that we're doing. So just a little bit about the patient safety strategy, which was first launched in 2019 and then was updated in 2021. The core component to deliver a safer culture, safer system and safer care for our patients. We've got 3 strategic aims. So the insights, so we're looking at how the measurement and any incidents that we can learn from, and the new PSERF is something that we're going to be helping with and supporting our system with when we receive that framework due in June time. Making sure we involve our system safety partners and the new patient safety specialists and such roles, and supporting the curriculum of training and safer culture, and making sure that we learn from these incidents as well, taking that safety 2 approach and being proactive rather than reactive. And then we have the improvement arm, which is where our National Patient Safety Improvement Programme sit. So for the past financial year, we've had 5 national priorities, and this is where this piece of work is sat around the COPD and asthma discharge bundles. So we've had a real focus on improving maternity and neonatal safety, managing deterioration, and a lot of you have been involved in the work that we've done around responding to COVID, especially the COVID virtual ward from a COVID oximetry perspective, but also from the respiratory perspective, which Emma will talk about shortly. So medicines safety, mental health improvement programme, and then we've had the adoption and spread programme, of which has had 4 interventions over the past year, with COPD and asthma discharge bundles being one of those. Now we do have a new commission for next year that does look slightly different, and you'll notice that our adoption and spread programme has come to a close. So that's the COPD and asthma discharge bundles as a specific piece of work, and the patient safety support to roll that out. However, what you'll really hear from today is how the COPD and asthma discharge bundles have been now embedded into our system and our pathways of care. So this work isn't stopping, it's just not being commissioned from a patient safety perspective from NHS improvement. But what it is, the respiratory work within the Innovation Agency and our national programme still exists, and this work will fall into that, and you'll see how that better aligns later. So I just wanted to make sure that clarity was there, that although that commission for COPD and asthma discharge bundles as an individual piece of work will be stopping on the 31st of March, the respiratory programme as a whole is absolutely continuing with our NHSE commissioned work, and will be continued to be supported through the Innovation Agency and our respiratory team there as well. But you'll see how this work has become embedded into practice and the plans going forward throughout this meeting today. So our core work really is underpinning all of our work streams, and we're commissioned to help develop safer systems that reflect continuous learning and improvement, creating conditions for culture, a safety culture to flourish, the understanding the learning from errors, and not having this blame culture, and understanding that actually a lot of the systems and the processes that we work in can sometimes hinder safety. So it's understanding, if we're having a digital system put on, how user friendly is that, and does it work? If I went into work and made a mistake today, could Verity come in tomorrow and make the same mistake because the systems and the processes haven't been thought through from that human factors element? A reduction in avoidable harm and variation to make sure we're standardising that care so there's not that postcode lottery, that shared improvement, and approaching to tackle health inequalities. The key functions are that engagement, engaging systems, so working very much with the ICSs as a whole, with our other Northwest partners, and then at CCG and PCN level and individual organisational level as well. Collaborating and making sure that the work that we're doing locally has that impact on national improvement, making sure we're doing measurement and supporting with that quality improvement work as well. And, you know, we're not measuring for measuring's sake, but we're actually looking at developing metrics that are meaningful, adding value, small tests of change, and then scaling up into bigger pieces of work. And we do most of our work through using quality improvement methodologies and the model for improvement, using a lot of PDSA cycles to test some of the change that we're doing so that we can then roll that out on a wider scale. So I'm going to stop there just because I've got noticed time, and happy to take any questions, or we can take some questions at the end. So thanks for listening, and really looking forward to hearing from all of our speakers today.
Thank you, Katie. That's great. Yeah, if anyone wants to raise a question at the moment, but if not, please add it to the chat. That's no problem. Okay. So what I'll do is I'll pass over to Emma to talk to us about virtual wards. Thanks, Emma.
Hi, thank you. Let me just share my screen. Hold on. Can everybody see that? Oh, I've done that again.
Yeah, just swap it around. Yeah, that's great.
Yeah, can you see? Okay, so I'm Emma Rickards. I'm the respiratory nurse consultant working at Liverpool Heart and Chest and Knowsley Community Respiratory Team. And I do recognise a few names that are in the audience, so apologies if you've heard this tale before. But just to set the scene, we are a community respiratory team, but we also have two substantive Band 7 nurses that work within Whiston A&E. And the reason that came about was to try and help reduce inequalities within the hospital, as there's 5 different CCGs that are in reach into that hospital, and we just thought if we had one streamlined approach that one nurse reviewed all patients irrespective of postcode and respiratory condition, then that would help a smoother transition back into the community setting. So as part of the virtual ward, the nurses that are called Swiss nurses, nurses without any borders, so obviously see anyone from any CCG. We embedded the virtual ward using the existing staff that we had to identify patients within A&E and AMU, but also to work together with the existing amazing respiratory nurses at Whiston who review patients on the respiratory wards and outlying wards. So it was a collaboration with the respiratory teams together, which has worked really well and kind of allowed us to do the discharge bundles from a more of an acute setting, and the respiratory nurses doing it from the respiratory wards. So it's been great working together on this. So obviously the COPD virtual ward model is a secondary care led initiative, and it's provided by Liverpool Heart and Chest in collaboration with Whiston, so STHK, for a 6-month period, and it started on the 15th of September last year. And as I've said, it's to provide early and safe discharges for patients with COPD. So the benefits of COPD virtual ward at home is to provide hospital care within the patient's own home, reduce the length of stay and free up hospital beds. As we know, hospitals are in crisis at the minute, so this has been an added addition to the winter pressures. Prevention of readmissions to hospital, which I'll touch on a bit more later, lower mortality and a reduction in cost of treatment by transferring care into the community setting where we're able to provide hospital expertise within the home setting. So patients before discharge are given a oxygen SATS probe, a blood pressure monitor and a temperature thermometer. And we initially, I've left the respiratory rating because that's something we really wanted to have, and there is some technology available to do that moving forward. All patients that are onboarded who identify as amber, which we'll move on in a minute, have a day 1 face-to-face visit. So we work together with other CCGs that if their existing COPD teams would be able to provide a day 1 visit for patients. If there are any difficulties and the respiratory teams were busy, then our team has tried to help where we can, and we've undertaken the visits within Liverpool and sometimes in Halton just because of pressures in other services. Then patients receive a telephone call on day 2, 3 and 7 to review symptoms, and there's a clinically agreed question set. So on those days, the nurse at Merseycare will go through a question set, and if the patient answers the question, we highlight it as green, then we don't need to discuss them on our ward round. If they come up as amber, then that patient is discussed on a daily ward round, and if it's red, then we would advise escalation to either hospital or as appropriate. The virtual ward implements an MDT approach consisting of specialist nurses, registered nurses, advanced practitioners and consultants who provide clinical oversight. So we have a consultant on call every day, which is a medical consultant, our physio consultant, Sam, who's on the call today, and myself, who provide clinical oversight and review all of the patients that have highlighted amber from the question set. And as I said, the clinician from Merseycare undertakes a telephone consultation on all those days and monitors the readings. So if there's any readings that are outside the parameters that we've set, then they will be highlighted as appropriate as well. So with the virtual ward pathway, so when we were developing this, we did initially liaise with Wiston Hospital, but then we put it out to the whole of Cheshire and Mersey, invited clinical leads to be involved, because if we're developing something, it's great to have consistency for all patients. So if a patient goes into a hospital in Chester, for example, it would be really good for everybody to have equitable care and follow up, irrespective of where they live. So working together, some of the barriers that we had initially is that some of the respiratory teams, if they haven't got obstructive spirometry, wouldn't accept that patient at all, even if you were pretty certain from a senior review the patient had COPD. So as part of this, we did actually work together to, if somebody's got a probable diagnosis of COPD, then we would be able to still onboard them and then refer them into the local diagnostic hub. So that's been a huge step forward for us as a service. But as you can see, the pathway is quite simple. If the patient has COPD, the triage to either green, amber or red pathway. If the triage to an amber pathway, we complete an early support discharge referral form and it's discussed with the Swiss nurse if required. The patient is consented and a referral sent to Merseycare, and then a day 1 visit is initiated. So we will alert the local COPD team, or it'll be ourselves, that'll undertake a day 1 visit. One of the questions I always get asked is, what if they need a day 2 visit or day 3? It's obviously clinical judgment. We would never expect someone to just receive a phone call if they were clinically unwell. But if all was going according to plan, then it would be the day 2, 3 and 7 follow-up call. If need be, like I said, the COPD team can undertake more visits. And if we're concerned on the phone calls, we can escalate back to the COPD team if required as well. And this is what the parameters look like. So again, these were agreed with other clinicians, and basically we already had a referral form with set criteria for discharge, and we just elaborated on those. So if a patient does come out as green, what we undertake is the COPD care bundle. So as part of this pathway, we've embedded the COPD care bundle. We've not had to set any restrictions with that. So if they're from A&E, from the ward, from AMU, everybody gets a COPD care bundle. So the limitations are, if we're not notified a patient, then we obviously can't go and review them. But we are very proactive, and we review patients within A&E that come in with shortness of breath or difficulty in breathing. We go to AMU twice daily to identify any patients that potentially could be going home. And what the system is that we have downloaded an app from Wiston, which they use for all of the referrals from different wards. So we've got a referral for a COPD review. So if somebody's going home and has a diagnosis of COPD, we'll get a referral on CareFlow, and then we can go up to the ward and then just do a handover between us. The care bundle for green, the idea of this is that normally this group of patients doesn't require community follow-up. So historically, what we do is we see a patient on the ward and we'll do a referral to their local COPD team, irrespective of the, what the parameters or how well they are. And often that's not a kind of best way to use those resources, especially when everyone's really busy and pushed. So those patients don't necessarily have any follow-up. We undertake the care bundle, so we're doing inhaler education, inhaler check, optimization, self-management and standbys if appropriate. onward referral to pulmonary rehab if they agree, smoking cessation and vaccinations. And we just undertake the normal paper copy, which can then be inputted, but we also put a sticker in the patient's notes just with all the information, just so it's easy, because Whiston still use paper notes. So we put a sticker in and do it that way. And even if somebody is on the green pathway, we still can undertake a home visit if somebody feels that that's appropriate, so that's not a problem. So the amber pathway, if somebody hits these clinical parameters, so they need to be stable on oxygen, white cell count less than 20, obviously not acidotic, the PO2 above 6.7 on air or on normal oxygen, and just if somebody's CO2 is above 8, just to discuss. Or if they fit everything on green but have just been started on a new nebulizer, we thought it best just to monitor that patient a bit more. And as I said before, it's a day 1 visit and then day 2, 3 and 7. The only difference on this is if somebody has started new on oxygen, or if we've changed their flow rate, then they will have what's called a light touch phone call, which will be done every week up until the 6-week oxygen assessment. And if they stop the oxygen, then that's fine, but if they continue on the oxygen, we'll just continue to ring them weekly. And obviously, as you can see, if they're red, then they're not suitable for hospital discharge. The figures that are on here aren't up to date. So for a 5-month period, we've had a total of 235 COPD care bundles that we've done. 147 of them were green. So in theory, we've saved 147 follow-ups from the local COPD teams by doing that. And 88 of them were amber. So we've onboarded 88 patients to the respiratory virtual ward round. To my knowledge, we've not had any readmissions for patients that have been onboarded to the respiratory virtual ward round or anything untoward. It's been really successful, and patients have given feedback that they felt more safe and secure, and we've had a lot of positivity from it. So much so that we're looking at rolling out our asthma virtual ward, which embeds the asthma care bundle as well, which we're currently undertaking, but not with the virtual ward, but we're doing the care bundles with an A&E in all the wards at the minute. And we're going to be rolling out our pneumonia virtual ward as well first, which is nearly done and nearly ready to go. I don't know how I'm doing with time, Verity.
Yeah, you're good. You've got a few more minutes, Emma. You're okay.
Okay, so one of the things that I just wanted to say, aside from this, is obviously the care bundle is developed to be used within the hospital setting, and lots of the models of work that we're looking at are how we can provide the same kind of level of care within the community as we do in the hospital. So I don't know whether you agree, lots of work that we're doing for patients with COPD have been pushed into the community. So we are providing hospital expertise within the home setting. So really, my view is that we should be recording a likewise care bundle within the home. So I know that NACAP is up for review in about the next 10 months to see how that's going to move forward and how we should be supporting patients with COPD. And we're currently been collecting COPD care bundles that we've done when we've reviewed someone on our respiratory ambulance, and we've been doing it as part of our rapid response team because it kind of makes sense. It's what we do anyway. If somebody's got a self-management plan, they're less likely to readmit to hospital because they know you're empowering them to be able to manage their own symptoms. And, you know, we're reiterating this every time we see a patient. So we would ask people to do the care bundle every contact that you have with a patient, because you're just reiterating, offering the same things, and just supporting them in a systematic way, and in a way that you're addressing, you know, the basics of COPD care that every patient should be entitled to. So that was my only thing, to see what people's thoughts were about undertaking a care bundle within the community as well, and collecting some data with regards to that. And I guess we've got some time for questions if anyone's got any questions.
That's great. Thanks, Emma. Yeah, I'd be interested if anybody had any comments about that community approach. We do have a question in the chat from Kath from Mid Cheshire Trust. So is the call for new O2 patients just for COPD patients, or do you do this for all O2 patients? I know this model is for COPD, but just curious. And she's also asked, do you have the example of the call template that is used? What is asked, measured on these calls?
Yeah, that's something that I can share. So I'll definitely pass the question set over to you. It's something that we use. So we do this COVID virtual ward round. So we've just adapted our question set from that in the same way. And it just works really well, you know, because news 2, we doesn't always adapt to community in the same way it does in hospital. So with the questions that we've done, we've kind of, instead of saying what a news 2 is, we've used different parameters. So I can share that. And the oxygen, obviously, for anybody else, we wouldn't do a weekly monitoring as a team, but we're doing it as part of the COPD virtual ward. But it's been working well, and I think patients have felt actually better having that contact rather than waiting 6 weeks.
Great. Thanks, Emma. Benita, did you have a question?
Yeah, thanks, Emma. Just two comments, really. One is, I think it's a great idea to do the bundles in the community, but I think one of the challenges with that is obviously how NACAP's, as you said, set up for hospital services. So maybe that's something we could take to the NACAP board to say, as integrated care systems develop, is there an option to have, you know, it adapted for community? So that's something we can definitely do. And the other thing is, have you thought about expanding your service to become more acute respiratory infection in general, kind of in line with the national conversation about acute respiratory hubs for next winter?
Yeah, so that
feels like the natural progression of the service.
Definitely, and that we're starting with pneumonia, so that pathway is actually done. So yeah, that's on our radar completely. So we've been all working together, the same team, to be able to undertake more in line with that.
Oh, I might steal your pneumonia pathway.
You can have it.
Is it all right?
Yeah, I did it ages ago, and then I wanted to change it so you could use the same pathway in the community as what you can in the hospital. But then, obviously, sharing some of the issues that we come by is that there's obviously 2 different guidelines, isn't there? There's the BTS guidelines for community, BTS guidelines for hospital. So we thought we would start with the hospital side first, then develop a different community pathway for GPs to refer into, and then see from there if we can then, because it's all work in progress, isn't it? And you can change and it's good to adapt, but just to get kind of what the appetite is for it, because I feel like the challenges are getting patients home from hospital with consolidation on their x-ray. Clinicians aren't quite keen to discharge, so we need to set very clear parameters to kind of give them the confidence that we've got a great service out there that can look after patients and free up hospital beds and get patients back home.
Yeah, and arguably, yeah, they're going to come to less harm in their own homes than if they're in hospital falling over and whatever.
Yeah, and if they were at home, we wouldn't necessarily know they've got consolidation on their x-ray because they might not have one. So yeah. Thank you.
That's great. Thanks both. So Benita, I'll hand over to you now, if that's okay.
Yeah, let me just put my hand down. So I'll just share my screen, and while I'm doing that, just introduce myself because I'm from across the other side of the Mersey. So I'm the respiratory lead for Health Innovation Manchester. I'm a chest consultant at Wythenshawe Hospital. And I'm going to talk to you about some of the work we've done in GM around the patient safety collaborative. So hopefully you can see my screen now. Let me just get that on slideshow. Now, I've decided to call it 50 Shades of Grey, not because it's going to be a very exciting talk, but I think because the more we've got into doing the NACAP, the more we realise that a lot of the stuff that we're being asked to do isn't clear cut, and there's lots of questions about, should this patient be in the audit, should they not, what does it mean by follow up in 48 hours and things like that. So we wanted to do a little piece of work around trying to standardise all of that. So across our 10 localities of Greater Manchester, we were all doing the same thing. Now I've got various touch points with the NACAP audit, so I've sort of lead clinician for it in my hospital. But obviously working at GM level with Health Innovation Manchester, but sit on the NACAP board as well. So I've got quite a unique perspective of having all of those different roles. So the first thing I want to do is just sort of go through the process that happens in terms of the data and the coding, because I think this is something that a lot of people haven't got their heads around, and can affect your quality of your results. It can affect your performance in the audit. So when a patient first comes into hospital, and I've used COPD as an example here, but clearly it would be the same for asthma, the idea is that they should have, as part of the standard, a specialist respiratory review within 24 hours, and that specialist can be a consultant, specialist nurse, it can be COPD team, but somebody who's got knowledge of the bundles and managing the disease. And then the care bundle should be delivered prior to discharge. And if you hit both of those targets in over 60% of your patients, that was that was the standard that you needed to meet for the best practice tariff when it existed. Obviously, over the last couple of years with COVID, we're not getting the best practice tariff. Patients then discharged, and if you're in a hospital like mine where we still have paper coding, the notes then go to the coding department. In an ideal world, the patient will have been coded correctly as having had a COPD exacerbation, but actually we do get patients where they've been coded incorrectly as something else, and those patients we might want to include in the audit, but wouldn't necessarily be identified by the audit department. For the audit department will pull the notes based on the coding, so they'll be missing out this particular group of patients in the blue. But they will also be pulling in patients who might not have come in with a COPD exacerbation and have been incorrectly coded as having COPD. So you get so the ones at the top should be included but aren't, and the ones at the bottom are included but shouldn't. The data is then entered into the NACAP database, and that's done very differently across different organisations. So in some hospitals, the audit department do it, in some hospitals, the clinicians do it. We have our own data entry clerk who that's her job, that's what she does. And so then there's a question of, when you've got your data in NACAP, is that data valid? What are you actually looking at in terms of COPD exacerbations and the quality of care you're delivering? So in our hospital, we decided to do it in two ways. So one is the real-time identification of patients. So anyone that we go in reach into the wards every day, we identify the patients, we get the referrals, and we make a list of all of those patients. Now, some of those will be identified correctly by coding, but some of them won't. So we make sure that if we have done a bundle and we've identified that patient, we include them. And then we also do that retrospective identification where the audit department has pulled the notes, and we make sure that we go through and make sure that only the patients who've got correct coding are entered. And that way, I think we have the purest data set that we can. However, our case ascertainment rate, which is how many patients are coded as COPD and how many are put into our audit, always is around 50%, because we're so picky about who we put in. But we can justify that figure, and we do send notes back to be recoded as well. And for those of you familiar with the KSS dashboard, if you've been working with the Innovation Agency on your bundles and looking at the individual elements of bundle delivery, that is all pulled from NACAP. So all of this data, how good it is, what you get out, really depends on the quality of the data you're putting in. And apologies if people are already familiar with this. This is when you log into the NACAP database, this is what you see. So if you're going to put a new patient in, there's a number of different tabs. You can see it's really quite a detailed data set that goes all the way from when they arrived all the way to when they were discharged. And it's very clear here that it's patients who are over 35 who have been admitted with a primary diagnosis of COPD exacerbation. And so if they've come in with chest pain and 3 days down the line they've been treated for a COPD exacerbation, you wouldn't necessarily include that patient. So as well as all the shades of grey around who goes into the audit, there's also, I was just going to say here, this is what the data looks like. So there's six different run charts that have real-time outputs. This is refreshed every 15 minutes, so at any one time you can see how well you're doing in the audit. So this is our, well, I'm hanging out our dirty laundry here. So this is our data. And what you have is the black line, which shows that patients have been seen within 24 hours by respiratory. You've got the green line, which says patients have had a discharge bundle before discharge. And then the purple sort of mountain range is whether you've met the best practice tariff. And then this is national average here. So you get really good data, and you can see that we were doing pretty well. And then pandemic hits January 2020, and it's all gone to the wayside. And we've sort of just started, we had just started catching up by the time I'd done these slides. So this is what I was going to say, as well as the shades of grey around who goes into the audit, there's a lot of shades of grey around the individual elements of the bundle. And this is important because the data shows that just doing a discharge bundle itself doesn't necessarily lead to improved outcomes. It's actually delivering every element of the COPD bundle that leads to that reduction in readmissions and hospitalisations in the future. And so the Patient Safety Collaborative has been not just looking at making sure that sites have implemented the bundle, but that we are delivering every element. And these are all the individual elements. Many of you will be familiar with these. I won't go through them. But there are a number of things that when you look at it, you think, well, okay, I've gone to see the patient, I've done their inhaler technique and their medication, self-management plan provided or referred to community respiratory team for plan. What if they already have a plan? So if you tick no for that, because they've already got a plan, are you then looking like you've not delivered that element? And then are you being sort of penalised for that? Same here, oxygen alert card provided, it's a yes or no. What happens if they don't need one? So I've not provided one because I've looked at it and they don't need one. How is that being, is that then sort of counting as not meeting that element of the bundle? What if they refuse smoking cessation? What happens if there is no smoking cessation team? So all of these sort of questions, and this one in particular, follow up within 72 hours by personal phone. I mean, what does that even mean? What qualifies as ticking that box or not? And again, patients being discussed at an MDT, and services are set up so differently. What does that mean? And they do say on the database that if any of the good practice care elements have not been completed and are not applicable, please do not select the items. They tell you not to tick it, but then a lot of the COPD bundle work we've been doing has been about achieving all elements of the bundle. So we wanted to have a go at sort of getting under this and making sure that people are doing things in the same way. So we had a few workshops in Greater Manchester. Well, you got all the COPD bundle teams together, and we thrashed out every standard, and we've come up with a sort of agreed definition. So I realise you probably can't see this. I'm very happy to share this afterwards, and I won't go through it in detail. But for example, self-management plan provided, what we've said is for patients without an existing plan, tick if it's been given and talked through. For those with an existing plan, tick if it's been reviewed and you've checked the patient's understanding. So it just puts a little bit of detail and clarity around each of those elements. As I say, really happy to share that. We've also, the other big sort of bane of everyone's life is rescue packs. It's good now that there is an option to say rescue pack not applicable. We're actually doing a lot of work to try and stop the rescue pack epidemic of prescribing. And so we've got some do's and don'ts that can be in a poster as well. Again, happy to share that. Just moving to asthma, again, similar issues. That, for example, these are the bundle elements. If there's number 4 is issuing a personalised asthma action plan. But it's actually quite challenging to do that in the acute setting, particularly if you've never met this patient before, you don't know what the baseline is. So what do you do? How do you tick that box? And again, specialist review requested within 4 weeks. What does that mean? Now, we haven't actually got as far as doing the standardisation for the asthma bundle yet, but that's obviously something we are looking to do. So the KSS dashboard, this was our sort of breakdown of the asthma bundle elements. So it looked like we were, we were doing really well, that patients were being seen within 24 hours. That's easy for us because we've got a selected respiratory take, so all patients get seen by a specialist consultant within 24 hours. But actually we weren't really doing well on delivering all elements of the bundle, and we were falling quite short of national average on all of these different things. So the first thing that we wanted to do was say, well, what's the data going in, and does it reflect the quality of care that we're providing? So one of our nurses then did quite a detailed piece of work where she looked at the sort of total number of bundles done, which is along this side of the graph, and then for each element she looked at how many of those per month had that particular element done. So here you can see in July we did 16 bundles, and 16 out of 16, you can't really see the green line because it completely it's on top of the blue line, but all of the patients had inhaler technique, and so on these particular elements of the bundle we were doing well. But as we moved into some of the other elements, like issuing personalised action plans, you can see that some of the bundles were done and they weren't delivered. And so she started doing a little bit of QI work to try and improve the bundle elements that we were failing on. And so I think the answer was that perhaps our data isn't as bad as it looked on the KSS dashboard, and we needed to tidy up how we were putting the data in and how we were collecting the data, but then we were able to use it to identify areas that we could improve, and again we were doing quite well on this, and then it sort of all fell off a cliff during 2021 because of ongoing COVID pressures. So nearly finished. So I think when my tip would be, when thinking about the NACAP audit, and as we're sort of agonising over this tick box and that tick box and whether that patient goes in and that patient isn't going in, taking a step back and saying, what is it that we're trying to achieve? At the end of the day, we're looking at patients with an acute flare-up of their respiratory condition getting the optimum treatment before they go home. And does the data reflect the care you're providing? And if not, how can we think about improving the quality of the data collection and entry? That's, I think, the first point, because you don't want to do things to make the numbers look better, but actually you want the numbers to reflect what you are actually doing at the same time if you're doing some good work. Is the patient the target audience for the audits? If you've got somebody with severe asthma who's in every 3 weeks having aminophylline infusions and is on absolutely everything in biologics, is that patient actually the target audience for the asthma audit? No, it's not, because they've already got a high degree of input and care, and actually they're already under a severe asthma service. You probably your target audience is your young, non-adherent patient who's crashed into A&E because their asthma's uncontrolled. Are we providing the best possible care? So again, let's not be reassured by our numbers if they're good. What else can we do to improve things? And how can we use that data to drive quality improvement on the ground? And that's just saying that in a different way. It's not about making the numbers look good, it's about improving care. And that's it, I think. So happy to take any questions on all of that.
That's great. Thank you so much, Anita. There are a couple of comments in the chat, not really specific questions, just referencing that it registers as 0% if not all achieved, even if not relevant. So when you were talking through the elements of the bundle. But yeah,
it is a problem because so I think the way the KSS, and I think we've got Tom from KSS, have we, on the call? Yes. So the way that, and you know, I think, and it's absolutely, you know, not a criticism of the KSS team because they've done an amazing job pulling that dashboard together, but it is a problem that if you don't tick something because it's not appropriate, it then scores as 0 and then you fail on meeting all elements of the bundle. So it's those sorts of details that we want to use the data to make sure, well, are we failing because we're not doing the work properly, or are we failing for reasons we can explain. Because at the end of the day, it's about just making sure that we're providing the best care we possibly can. Yeah, happy to share slides, Joanne, no problem. Oh, and the posters, I appreciate you couldn't see those. Yeah, absolutely.
Thank you. Tom, did you have a question?
It was just to
comment?
Reaffirm what Binny's been saying, really, is I think doing this has been a massive learning process, hopefully for NACAP as well. So when we started off the process, the ability to mark that a discharge bundle, or at least the rescue pack, wasn't eligible for the patient never existed. So that's something which is sort of only just come into the audit relatively recently. When we receive the data, each column is a bunch of ones and zeros, and unfortunately there's no 0.5s for patients who it's not eligible for. So we do our best with the data, but you're entirely right. It really is also down to your local service being able to interpret it. You know your service best, and it's for you really to interpret it how you wish. But it's a baseline. But again, as I say, NACAP, they're doing some exciting things. The data is going to be made publicly available now. So it's only through people challenging it that we can make it better.
Yeah, and I think for the complexity of the task and the number of people involved, the number of patients involved, you know, it's a really great data set. And I say the key is not looking at the data and going, oh, we're doing a terrible job. It might be, OK, let's try and get beneath this, understand it. And we've shown that we weren't doing as terrible job as we thought, but there's definitely things we could improve on. And that's what it's all about, really.
Great. Thank you for that. So we'll move on to our next speaker now. Please feel free to keep putting any comments or questions in the chat. That's great to hear from you. So Sam, I'll hand over to you. Thank you.
Thank you. Let me attempt to share my screen. Bear with me. Runs. Can everyone see that?
Yeah. Yeah.
Lovely. Right, so just while that's loading, just to introduce myself. So my name's Sam Pilsworth. I'm a consultant respiratory physiotherapist. I work at Liverpool Heart and Chest Hospital and in the Knowsley Community Respiratory Service. So thanks for asking me to come and talk to you today about, you know, a topic that I feel really passionate about. So I want to sort of try and impress on you the importance of early referral into pulmonary rehab, particularly those patients that have come into hospital, which is why I've named this The Early Bird Catches the Worm. It was slightly catchier than my benefits of post-exacerbation pulmonary rehab title. I'm very happy to share the slides afterwards, so I'll make sure you all get a copy of those, but that's just what I'm going to do a whistle-stop tour of today. So hopefully you all know what pulmonary rehab is. So it's defined as a multidisciplinary programme of care for people with chronic respiratory impairment. So after a thorough patient assessment, it's an individually tailored programme designed to optimise each person's physical and social performance and autonomy. And that's just lifted from the NICE guidelines. So it's indicated for patients who have chronic respiratory disease, who have a decreased exercise tolerance, exertional breathlessness, fatigue, and or impairments of activities of daily living. So if you think about the cohort of patients that we manage with COPD, essentially pretty much every patient would be eligible for pulmonary rehab. And it should be one of our fundamentals of COPD care. And I think it's something that, you know, we're getting better at, but we're not great as health professionals at providing this for patients. And I like this slide from NICE because it just sort of confirms actually every single clinical contact you make with patients, we need to be doing these fundamentals of COPD care and this COPD bundles that everyone's been talking about today. So we should be offering pulmonary rehab if indicated at every clinical contact with this cohort of patients. So how do we select patients? Well, there's a whole long list of inclusion criteria in patients that we know will benefit from pulmonary rehab. Obviously, the most research is in the COPD cohort, but we also know from evidence that a whole lot of other respiratory conditions will benefit from this intervention. Now, asthma patients will benefit, but routine referral is not recommended. So it's only for those sort of small group of asthma patients where they might have sort of difficulty in activities of daily living. Bronchiectatics, patients with interstitial lung disease, restrictive lung disease will all benefit from coming to rehab. Pre and post-surgical lung patients will also benefit, and pre and post lung transplantation. Patients with hyperventilation or dysfunctional breathing also benefit further down their sort of treatment programme when they have better control of their sort of breathing pattern disorder at rest. Obviously, patients who've been hospitalised with an infective exacerbation of COPD, and I've put at the bottom, some COVID patients will benefit from a pulmonary rehab type approach for their rehab. But we have to be really, really careful with the long COVID cohort of patients, because, you know, a vast majority of those are suffering from post-exercise malaise, and any sort of structured graded exercise programme will make them worse. So it's just to bear in mind that this isn't the right approach for all patients. Now, those patients that we exclude, it's very few and far between, really. It's essentially anyone with any sort of unstable cardiac problems, or they've had an acute cardiac event within the last sort of few weeks, or if they've got, or if they're very hypertensive. They do, when you read the guidelines, it says sort of patients with lack of motivation, patients with severe musculoskeletal or neurological disorders, and patients with severe psychiatric disorders. But I've added a little however here, because actually I think what we need to be doing is modifying our approach, putting the right support package in place for those patients so they can exercise and they can access some level of pulmonary rehab. I think patients that have limited mobility and struggle to exercise, they might not benefit from the exercise component of pulmonary rehab, but actually could we offer them the education only components, because they will learn self-management sort of techniques that is really important for their ongoing disease management. So when we look at the quality standards and the BTS guidelines for pulmonary rehab, they really recommend COPD patients with an MRC dyspnea score of 3 to 5 should be offered pulmonary rehab. But also within, when you dig into the finer detail, they actually recommend that if patients are functionally limited by breathlessness, so MRC of 2 and above, we should be offering referral into PR. Now, I know this causes issues with commissioning, because some services have only commissioned for MRC 3 and above, but actually we should be opening up pulmonary rehab services to more patients. This slide is just to sort of stress the point that actually we shouldn't use lung function to determine whether patients are eligible for pulmonary rehab or not, because we know lung function bears no correlation to exercise capacity. So I think it's just to sort of reinforce that actually no one is too severe in their sort of FEV1 to be able to sort of get some benefits from coming to some sort of pulmonary rehab. Now, the evidence base for this intervention is vast. It's overwhelming. There's huge amounts of evidence to support the effectiveness of pulmonary rehab. Interestingly, Cochrane put out a statement a few years ago, and actually to say that we don't need any more randomised control trials into the effectiveness of pulmonary rehab. We know it works. But actually what we need to do is find out the best way to deliver this intervention to target, you know, the patients who will benefit. So pulmonary rehab is supported in national and international guidelines. We've got the BTS guidance, which is out for review, and hopefully there will be an interim statement. We've obviously got the National COPD Audit Programme. We are there, that features very heavily in the NICE guidelines. And also you can see the infographic in the middle. This is work done by the Chartered Society of Physiotherapists and University College London. And they've looked at actually if we referred all eligible COPD patients into pulmonary rehab and they completed their programme, the benefits that this would you know, generate for the wider healthcare system. And I think when we're thinking about all the pressures that the health service is under, this, you know, this infographic is really important. It shows how many hospital days we could free up, how many admissions we can reduce, and actually what sort of numbers of primary care appointments we can free up just by optimising patients' COPD care and getting them to complete pulmonary rehab. Now, this slide is purposely busy, and I've done a whole long list of benefits of rehab just to sort of stress really all the wide-reaching benefits that actually patients will get if they come through and complete pulmonary rehab. And it's not just about their sort of like reducing hospitalisations. It improves their health-related quality of life, reduces social isolation, improves anxiety and depression rates. It changes the muscle structure and function. So it's a really, really powerful intervention. And you can see by the pyramid on the other side of the slide that it's a highly cost-effective treatment as well. You know, sort of second only to sort of flu vaccination and stop smoking support. So we really need to be supporting patients to engage in this intervention. Also, you know, for those patients that we are, you know, suspecting COPD or they haven't yet been diagnosed, we need to be better at promoting better physical activity in this cohort, again, to get these highly cost-effective interventions for patients. Now, when patients do come to pulmonary rehab, they have a really thorough assessment. If they are then suitable for the programme, then we will have we'll carry out an exercise capacity test and we'll do some quality of life measures. The programme itself is really individually tailored and exercise is prescribed individually to each patient. But it's not just about exercise, and I think that's one thing that everyone thinks when they think about pulmonary rehab. It's just that the patients come to exercise, but it's about this, you know, we review the patients really holistically, and we try and encompass all these core components of actually patients' care. So we don't just focus on sort of like how far they can walk. We try and facilitate smoking cessation. We're improving social networks with patients, improving mental health. We will, you know, talk to patients about advanced care planning. We will optimise their sort of pharmacotherapy management, and then we will instill all those self-management techniques and try and create conditions where they can make, you know, good decisions about their healthcare and to change their healthcare behaviours. Programmes normally last for sort of 6 to 8 weeks, and patients will have 2 supervised sessions and 1 unsupervised session a week. Now, when we think more specifically about post-exacerbation COPD, I think we've got a long ways to go and how we can try and improve care. When we look at the COPD NACAP secondary care audit from 2019, about 56% of patients that were admitted into hospital were assessed for their suitability for PR, which, you know, that's a huge group of patients that we're missing out on. So that's certainly a flag of something that we can do better as a sort of a healthcare community. But the other interesting thing is, I think that even when patients are assessed for suitability, that doesn't translate into patients being referred into pulmonary rehab, because when we pull data out from the COPD audit, from the pulmonary rehab audit, only about 5% of those patients included in that audit were referred after an admission to hospital. So there's something going wrong in that pathway, and I don't think we've obviously got that pathway right. And if you look at which who offers post-exacerbation pulmonary rehab from the top sort of little picture, I know it's quite small, but about 94% of pulmonary rehab services in England do offer post-exacerbation COPD pulmonary rehab. And it's in the quality standard guidelines that we should be offering this intervention. So there's some sort of disconnect in that pathway, and this is a huge opportunity for us to do something a little bit different and a bit better. Excuse me. So this is sort of like the good, the bad and the ugly, if you like, of post-exacerbation PR. So we know actually if patients who have been into hospital come to PR within 4 weeks, then actually it's one of the only sort of known interventions that can really reduce that 30-day readmission rate. So it's a really powerful intervention. We know it improves quality of life, improves short-term exercise capacity. It's a safe intervention. There was no sort of increase in mortality for these patients that were exercising, and we can increase their muscle strength and endurance. But we know we've got problems, as I've mentioned before. You know, there's a low referral rate. So this paper from Jones looked at the referral rate for post-exacerbation PR, and they worked out as about 10%. So that's almost sort of double what the national COPD PR audit shows it to be. So we know the uptake rates are poor. There's high dropout rates in this cohort of patients. And we know there's significant staffing pressures on how we can manage this cohort, because ideally we want to get them into rehab within 4 weeks. But that is a challenge for a lot of services. There's been loads of research that shows sort of like low healthcare professional awareness of post-exacerbation pulmonary rehab and pulmonary rehab in general. As I've mentioned, I think the pathways to get people in and get patients in after they've been into hospital perhaps aren't the best at the minute. And I think some clinicians and some patients actually, they feel that they're too unwell to exercise and they shouldn't be exercising, when we know that there's huge benefits to exercise in this cohort in a safe way. We've got really long waiting times within pulmonary rehab. That was sort of very evident sort of pre-COVID. I think the target we've been set from the National Audit Programme is 90 days from receipt of referral to start pulmonary rehab. But we know with the post-exacerbation cohort, we need to get them in much sooner. And actually COVID has made those waiting times worse. Services have had to be suspended for, a lot of places. We've had to work in very different ways. We can't get the number of patients in groups at the minute because of COVID restrictions. So COVID has exacerbated our already dire waiting lists. I think post-exacerbation PR isn't commissioned separately, which leaves it to be a little bit forgotten about, and there isn't that finances to support getting those good services with short waiting times. And I think because of the pressures that PR services have been under recently, they might not always be able to be flexible that they need to be to meet this patient need. So it sounds all doom and gloom, but it really, really isn't. So again, there's a Cochrane review about post-exacerbation PR done in 2016, which shows it's a really safe, effective treatment for this cohort of people. And actually, when we think about doing COPD discharge bundles, there was a paper by Barker, which was published in Thorax last year, and they looked at putting clinicians with expertise into the hospitals doing the COPD discharge bundles. And they found that there was a significant increase in patients accepting PR, but then also that translated into the patients themselves turning up to PR post-discharge. So that shows that actually we can modify this sort of patient behaviour of not uptaking pulmonary rehab. So there are things that we can try and do to improve that sort of element of care. So what does the future look like? Well, pulmonary rehab's in the long-term plan, which is brilliant. And we've got some NHS funding coming our way, which will really help sort of bolster and support services. But there's loads and loads of opportunities. With all the virtual ward stuff that's going on, there's opportunities for pulmonary rehab teams to link in and to support the virtual ward patients that we're onboarding. So those amber cohorts, we need to be picking that group of patients up. COVID has helped us to adapt as pulmonary rehab teams, and we've got virtual pulmonary rehab options. And is this the way to try and tap into patients in a slightly different way, but doing this over a larger footprint rather than lots of teams trying to develop their own services as ICSs? Is that something that we can support? We need to be supporting and developing new pulmonary rehab pathways to be able to offer flexibility, and that's something that we're really looking at in Cheshire and Mersey, and how we can do things a little bit differently to try and target this group of patients that will really benefit from the intervention. We've got lots of digital inclusion work going on, and because we need to make sure we're not leaving any patients behind. And actually what we need to be doing is starting to work with our charity and voluntary sectors and social prescribing to support patients in different ways, and particularly post-pulmonary rehab. So in summary, we really, really need to be supporting our patients to attend pulmonary rehab, and particularly in those cohort of patients that have been admitted to hospital or racking up to A&E. And there's huge benefits to the patient, but also that wider health economy. Post-exacerbation PR is safe and it's an effective intervention. However, there are significant challenges which we need to overcome. But we know that actually when we're offering pulmonary rehab as part of COPD discharge bundles, particularly by clinicians who have got experience in pulmonary rehab, that can really improve uptake and attendance within PR. Hopefully we need to start to be building links for our local pulmonary rehab local pulmonary rehab teams, so we can build those pathways to get these patients in. So hopefully, that take-home message for all of you today is to be that early bird and to start linking in with your patients. Thank you.
That's great. Thanks so much, Sam. That was a really good overview. Lots of great information there. There is a question in the chat, but I'll ask you if you'd be kind enough to respond in the chat box so we can move on to our next speaker.
Yeah, of course.
Okay. So thank you. So Tom, I'll bring you in now to talk to us about that national and local improvement with the bundle works.
Fantastic. Right.
Tom.
Hoping you can all see my screen.
Yep.
And now I'm going to put it in PowerPoint mode and it will show the wrong one. Yep.
Yep.
Great. How's that? Can you see my slides now?
Yeah, thanks, Tom.
Okay, then. So, hi all. My name is Tom Myers and I'm from Unity Insights. We were formerly the metrics team from KSSA HSN, but there's been a bit of a structural change there. I am the person who has been administering the COPD and the asthma dashboards for the past couple of years. And Katie and Verity, they've asked me to come along to sort of just show you some of the success that we've had with the national programme, and I just want to use this as an opportunity really to say thank you. So I mean, I spent a while trying to dig out these photos, but again, the team kindly invited us up in 2019 to come and present the work just as the programme was getting going. It was a rather chilly day in Cheshire. And we came away from that event knowing that we had some hurdles to tackle. And as Binny sort of summed up perfectly, we had data issues, ensuring that all trusts were trying to record the data in the same way. And there's over 100 trusts that we had to try and work through this with, through the 15 regions. We had data literacy hurdles where we were trying to cater the dashboard for all sorts of varying skill sets when interrogating charts. But the one hurdle that we didn't realise we'd have would be a global respiratory pandemic. So if you recognise these tools, if you've picked up the phone when Katie's given you a ring or she's asked for a meeting to discuss the patient safety work, I just want to say a really big thank you, because I understand that it's been so difficult to try and find 5 minutes to even look at some of these charts. But in the subsequent slides, I just want to show you that there has been a difference that's been made. Just through context in the national sort of theatre and the meetings that we have, Katie's also been a fantastic champion for the region. She's done a great job of articulating the struggles and the challenges that you've had in the Northwest. So a big thank you to Katie as well. So just going to fly through some really brief charts. And they're showing data very similar to what you can get in the dashboard at the moment, but I just wanted to evidence some of this today. So what we're looking at is the number, the blue bars here are the number of patients that have received every element of the COPD discharge bundle. And this is nationally for each quarter for the past couple of years. What we've got here is the teal line is the number or the percentage of patients that have received all measures of the bundle. So those of you who are familiar with the dashboard, it will be what we refer to as the ACS score. We had a couple of bumps. COVID came along, knocked it down a bit. We saw seeing very similar trends with the wave of Omicron. But as we can see, there's been a nice sort of steady progression in the percentage of admissions receiving all elements of the bundle, or at least the way that it's been coded to show that. And this is using the same calculation for every quarter. So there has definitely been a change in behaviour in delivering the bundle, or the way that it's been coded over the past couple of years. And again, these comments kind of just restate what I've just said. So what we wanted to do was just to understand what sort of impact has that had in terms of the actual number of admissions. We can see that the percentage has increased, but at the moment what we reckon is that there's about just short of 1,200, and this is of Q3 of 21-22, just short of 1,200 patients that have received a more complete discharge bundle, a full discharge bundle, compared to the baseline being sort of Q3, Q4 of 2018-19. And again, we can see that we've had some difficulties. The programme first got going and there was little change from the baseline, as you'd expect with any sort of quality improvement programme. We started seeing some improvements. COVID came along and scuppered all of those improvements. And then ever since, as services have, well, I don't want to say improved, have sort of come to terms with COVID and have started to re-deliver the COPD discharge bundle, again, we've seen that steady increase in the number of patients or admissions benefiting from the work that you've been delivering. So this is all on a national sort of scale. Similarly, we've had the asthma work, and I'll give less focus to asthma because it started at the worst possible time. The baseline using the like 19-20 year. The moment the program got going, COVID came along, and so performance did fall below the baseline, which is why we've got this sort of negative territory going on here as to the number of patients that actually benefited from the work. But again, it follows a very sort of similar story now, that in the most recent couple of quarters, there has been a significant improvement in the number of patients receiving all elements of the bundle as per the data. And again, I won't talk through all of this, but we're looking at just short of 500 at the moment. So then what I wanted to do was actually just show you innovation agencies' improvement. And as you can see, it very closely follows that sort of national trend that we saw in the earlier chart. We unfortunately got hit by COVID, but nonetheless, the services were able to bounce back. And what's quite interesting, in fact, is that the number of patients benefiting, the raw counts, are not too dissimilar to what they were before the pandemic, despite the fact that we've seen significantly fewer patients be recorded into the audit, be it because they're not presenting at hospital or because the audit teams have just not got the time to be doing it. And also there's been the policy change at NACAP to sort of make the audit not mandated for the period of time at which there's been workforce issues. So again, this has just been fantastic. We started from a very low sort of percentage adherence, and at the moment there are caveats to the most recent data points, but it's floating around 30%. It's fantastic. So again, looking at the raw number of patients that we reckon have benefited from the program, for Innovation Agency alone, it's floating just beneath 400. So it's a real success of the program. It's when you go to the dashboard, it's all in percentages, and it's really hard to actually understand on the ground how many people have benefited from it. And I can interrogate the data, and I reckon that we're just short of 400 patients at the moment. And considering all of the circumstances for the past year, I think everybody within the region has done such a great job. For asthma, as I was suggesting, things unfortunately just got going at the perfectly wrong time. This is your sort of baseline period here. COVID came along and it's taken a while to bounce back. There's not much we can do about that. What I also wanted to do was just provide a bit of an update on the dashboards for those of you who are still accessing the dashboards or wish to access them in the future. So we're going to continue updating the dashboard until the AHSN is done with its Q4 reporting. So that's looking at sort of June, July time. So the dashboard will be available until June to July. Katie and the team will actually have access to the dashboard till longer. They'll have access until a sort of December time, at which point we've then got to destroy the data and the dashboard will go offline. So for those of you who, as I say, are continuing to access the dashboard, you'll have it until June, July time, at which point we then have to turn it off, unfortunately, for trusts accessing the data. But a good news story out of this is that NACAP are developing their own suite of tools now, which is far greater than anything they've provided previously. So NACAP will be making a select number of data fields available publicly on a slightly more frequent basis. So you'll be able to access not only your services data, but also other services data, which is something which isn't currently offered within the NACAP tool. And I think this is really exciting. So they're going to be releasing PR data, asthma data, and COPD data on a suite of things beyond just the discharge bundle. So yes, unfortunately, the dashboard will be coming to an end in the summer, but there will be new tools for you to sort of support any further quality improvement programs that you wish to run. That's just a really quick update from me. And again, I wanted it to be a thank you for all the hard work that you've done over the past couple of years. I recognise it's been incredibly difficult. But at that point, I'm happy to open up to any questions.
Thank you, Tom. That's great. That's a really good overview.
I'm just going to take the opportunity just to jump in quickly here. I can see there's we haven't got anyone hand up, but I think, you know, we've also got to say a massive thanks to you, Tom, for all the information that you've provided to us and pulled from the dashboard and being able to make sense of it and feed that information back into us as well. And I'm just like to, oh, I knew the dog was going to bark. I'd just like to also say thank you for acknowledging the work and the difficult period we've been in the Northwest as well, because I think it's really good for everybody on the call to understand that NHS England Improvement have listened to that and understood the position that you've all been in over the past couple of years. So thanks for taking note of that as well.
That's That's great. Thanks so much. So what I'll do now is we'll just take a couple of minutes just to wrap up the session. I'll just share my screen with you just to talk you through some elements around looking at sustainability. So has that come through okay?
Yep, perfect.
Is that okay? Fab. Okay, so obviously we've touched on this an awful lot as we've gone through the session today. Myself and Emma just wanted to wrap up the session and obviously say a thank you for everyone to join us, but thinking about all this hard work that's happening, how do we keep it going? How do we keep that momentum going? There's a whole host of top tips that have been discussed within the network, within different clinical teams and amongst the Patient Safety Collaborative, and we just wanted to share those with you. Of course, a lot of it will make perfect sense to you and you may be doing it already. So it's just thinking about, of course, that MDT approach, which we've had some great examples of here today. Clinical leadership buy-in, do you feel that you've got that power within your clinical teams to drive this work forward? And again, clinical champions, do you have designated staff within your teams that are there to help you share the message around these pathways and really help to embed this work? Policy levers, again, we've touched on this already in terms of the long-term plan, is a great example for respiratory services. Local engagement strategies, so thinking about what's happening within your organisation. Are you speaking with the right people? Are the right people aware of what's happening in terms of your services and the pathways that you're using? And QI tools and kits that can be shared, again, depending on the organisation that you work in. Is there a resource that you can tap into or a colleague at all to help you from a quality improvement perspective to be able to drive this work forward and keep that momentum going? And again, active social media presence, it's thinking about that network and generating good contacts and sharing and embedding that work as much as possible. So thinking about next steps within this work. So we've touched on all these elements already. So the asthma and COPD pathway. So we know from Emma's work in the field that there is apparently some interest to adopt this at a national level, and there's some work going on in the background there. From a virtual ward perspective, this has been touched on a number of times by our speakers today, and obviously it's sharing any connections you have there and try and utilise that service as much as you can with your patient groups. And again, Tom's touched on the public availability of the NACAP data, which will change from this summer, which is great to know. Benita touched on this as well within her presentation. So yes, it's just to sort of try and round up all the information that we've talked through really. Our contact details are here as well. So for myself and for Emma here at the Innovation Agency. So yeah, happy to take any comments. Emma, I don't know if you want to add anything in at this time.
No, yeah, I just want to say again, thanks to all the speakers as well. It's been really interesting to see different perspectives, and I really enjoyed listening about pulmonary rehab as well, because I do think it's something that often goes under the radar, and the importance of it shouldn't be underestimated, as Sam's illustrated. But this is an opportunity, it's not the end, and I think it's really important to keep these connections going. My email and Verity's email is available, and just to work together to try and help each other adopt and spread lots of the good work that's being had. And like I said earlier, lots of these things are trial and error. Nobody's saying it's easy. As Tom said, everyone's done amazing. We've had a really difficult couple of years, but we're here to support each other and take things forward. And yeah, I just want to say thanks to everyone for joining us today.
Thank you. Katie?
Yeah, thanks very much. And just on the back of that, very conscious that this collaborative was formed for the learning and sharing network. And, we've obviously stimulated a lot of conversation again and ideas again today, and we don't want it to end here. So I think what we need to look at is how some of this can continue going forward. And I would expect it's probably through the network, respiratory networks, Emma, isn't it? But I think we probably maybe just need to think about that when we do a follow-up email to everybody with a link of the recording of the presentations. A suggestion of where some of this discussion can continue and what forum can be put there so that this work just doesn't go away, because it is very well embedded up in the Northwest. with the work that you're doing in CNM as well, and the work going on in South Cumbria. And yeah, we just need to find what forum would be best placed for everybody on the call today sort of to attend in the future as well. So we've still got that, and I anticipate it will just get bigger and bigger as well, really. This work absolutely isn't going anywhere. So that's fabulous. Thank you.
That's great. Absolutely. That's a great point raised. Thank you, Katie. So yeah, so we've come towards the end of the session today. If anyone has any final comments or queries, please let us know. Otherwise, thank you so much for taking part and sharing this work with us. And again, thank you to all our speakers today.